Dear class, this presentation covers antiarrhythmic. In contrast to skeletal muscle, which contract only when it receives a stimulus, the heart contains specialized cells that exhibit automaticity. This means that they can intrinsically generate rhythmic action potentials in the absence of external stimuli. These pacemaker cells differ from other myocardial cells in showing a slow, spontaneous depolarization during diastole phase 4, caused by an inward positive current carried by sodium and calcium ion flow. This depolarization is fastest in the sinoatrial or SA node, and it decreases throughout the normal conduction pathway through the atrioventricular or AV node to the bundle of His and the Purkinje system. Dysfunction of impulse generation or conduction at any of the number of sites in the heart can cause an abnormality in cardiac rhythm. Dysfunction causes abnormality in impulse formation and conduction in the myocardium. However, in a clinic, arrhythmia presents as a complex family of disorders that show a variety of symptoms. For example, cardiac arrhythmia may cause the heart to beat too slowly, bradycardia, or too rapidly, tachycardia, and to beat regularly, sinus tachycardia, or sinus bradycardia, or irregularly, atrial fibrillation. The heart cavity from which the arrhythmia originates gives the name to the arrhythmia. To make sense of this large group of disorder, it is useful to organize the arrhythmias into groups according to the anatomic site of the abnormality, the atrial, the AV node, or the ventricles. This figure summarizes several common occurring atrial, AV junction, and ventricular arrhythmia. Most arrhythmia arise either from aberration in impulse generation, abnormal automaticity, or from a defect in impulse conduction. Abnormal automaticity may also occur if the myocardial cells are damaged, for example, by hypoxia or a potassium imbalance. This cell may remain partially depolarized during diastole and therefore can reach the firing threshold earlier than the normal SA cells. Abnormal automatic discharges may thus be induced. Most of the antiarrhythmic agents suppress automaticity by blocking either sodium or calcium channels to reduce the ratio of these ion to potassium. Impulses from higher pacemaker center are normally conducted down pathways that bifurcate to activate the entire ventricular surface. A phenomenon called re-entry can occur if the unidirectional block caused by myocardial injury or prolonged refractory period result in an abnormal conduction pathway. Re-entry is the most common cause of arrhythmia, and it can occur at any level of the cardiac conduction system. Antiarrhythmic agents prevent re-entry by slowing conduction, as in class 1 drug, and/or increasing the refractory period, class 3 drug, thereby converting a unidirectional block into bidirectional block. As notable, antiarrhythmic drugs can modify impulse generation and conduction. More than a dozen such drugs that are potentially useful in treating arrhythmia are currently available. However, only a limited number of these agents are clinically beneficial in the treatment of selected arrhythmia. For example, the acute termination of ventricular tachycardia by lidocaine or of supraventricular tachycardia by adenosine or verapamil are examples in which antiarrhythmic therapy results in decreased morbidity. In contrast, many antiarrhythmic agents are now known to have dangerous pro-arrhythmic action, that is, to cause arrhythmia. Class 1. Quinidine is a prototype class 1A drug because of its concomitant class 2 activity, it can actually precipitate arrhythmia such as polymorphic ventricular tachycardia torsade de pointes, which can degenerate into ventricular fibrillation. Because of the toxic potential of quinidine, calcium antagonists such as amiodarone and verapamil are increasingly replacing this drug in clinical use. Brocainamide, a derivative of the local anesthetic brocaine, can cause a reversible lupus erythematosus-like syndrome that develops in 25 to 30% of patients. Class 1 antiarrhythmic drug act by blocking voltage-sensitive sodium channel via same mechanism as local anesthetic. The decreased rate of entry of sodium slows the rate of rise of phase 0 of action potential. Class 1 agents slow the rate of rise of action potential, prolong the action potential, and increase the ventricular effective refractory period. Class 1B drug decrease the duration of action potential by shortening repolarization. Class 1C agent markedly depress the rate of rise of membrane action potential. So class 1C is slow onset, 1A intermediate onset, and 1B rapid onset. Class 2 agents are beta adrenergic antagonists. This drug diminishes phase 4 depolarization, thus depressing automaticity, prolonging AV conduction, and decreasing heart rate and contractility. Class 2 agents are useful in treating tachyarrhythmia caused by increased sympathetic activity. Metoprolol is a beta-1 antagonist that is most widely used in treatment of cardiac arrhythmia. Esmolol is a very short-acting beta blocker used for intravenous administration in acute arrhythmia that occur during surgery or emergency situations. Inhibition of potassium channel class 3 activity widens action potential, leading to a prolonged QT interval on electrocardiogram. Such effect is associated with increased risk of developing life-threatening ventricular tachycardia, torsade de pointes. Amiodarone contains iodine and is related structurally to thyroxine. It has complex effect showing class 1, 2, 3, and 4 action. Its dominant effect is prolongation of action potential duration and refractory period. Amiodarone is effective in treatment of severe refractive supraventricular and ventricular tachyarrhythmia. Amiodarone has been a mainstay of therapy for management of atrial fibrillation. Class 4 drug are calcium channel blocker. They decrease the inward current carried by calcium, resulting in decreased rate of phase 4 spontaneous depolarization. They also slow conduction in tissue that dependent on calcium current, such as AV node. Although voltage-sensitive calcium channel occur in many different tissues, the major effect of calcium channel blocker is on vascular smooth muscle and the heart. Adenosine is a naturally occurring nucleoside, but at high dose, the drug decreases conduction velocity, prolong the refractory period, and decrease automaticity in the AV node. Intravenous adenosine is drug of choice for abolishing acute supraventricular tachycardia. Adenosine has an extremely short duration of action, approximately 15 seconds.